talk and Dr. Marine's talk. So whatever few things I just wanted to make comments about that. The first thing is I probably tend to disagree on the 95% which Dr. Marine told. Because you can anticipate at least 50% of the zonal weaknesses if you look at the eye very carefully. So once you anticipate a zonal weakness, obviously in an OT like ours, where you have 7 tables running simultaneously, a lot of extra hooks and rings and everything always available. I know it's easy for me to comment, but in a place where you were working earlier, not now, where you are a single surgeon, where you are a single surgeon, I don't know how many of you are single surgeons here, having just 1 or 2 extra pairs of iris hooks. And sometimes you take it and it may not be used for 1 year or 2 years, and then suddenly you have one bad zonal dialysis one day. So I think these are things that you have to have. And I consider that modern cataract surgery without Utrata and microrhexis forceps, it should not be done. You need these 2 instruments. They are very, very valuable. Have few good sets. Take it out once in a while, see whether it's working. Suddenly you have a rip-off, you ask for a microrhexis, it doesn't open. Then you ask, then the nurse runs around for a second microrhexis forceps. So I think these are some valuable points that you can have. Regarding the central button about which Dr. Sandhya told, quite often the central button separates from the rest when the crack is not complete. So you have the central button there. The central button, as you said, can be emulsified, but the remaining bowl is cracked in many areas but joined at the center. Okay, so that is something that you get quite often. So there are 2 ways to handle it. One is you put enough amount of viscoelastic, and if it is not too soft, you can use 2 Sinskey hooks to just separate the pieces and make it separate and then aspirate. Or sometimes if you're in a hurry, you've been doing for quite some years, I think Minu also agrees with me, just lift the central portion. I call it the guillotine technique. Just lift the central portion, and with the phaco itself, just give a few bursts there, so the central connection separates. And then you can aspirate each piece. This is my experience that I want to share. Regarding the striae during rhexis, about which Dr. Marine mentioned, when you see a striae, 100% of the time it does not mean that it is a zonal weakness. There are conditions where you see striae. For example, an eye with retinitis pigmentosa, sometimes when you do a rhexis, it need not be a zonal dehiscence. You can have a striae in RP with a normal zonium. You don't get a zonal dehiscence, but you see normal striae in cases of RP. Yeah, it doesn't, the RP zonules usually don't give way during the procedure, unlike a zonulopathy of pseudo-exfoliation. That is the point I'm trying to make. And I have observed it, I don't know whether Minu agrees with me, I have observed it in quite a few cases of angle closure glaucoma. Now, when you have a very shallow AC, you have a very convex configuration of the angle. Other than the shallow AC itself, I have observed that these striae and difficulty in slide difficult, whether it is due to the chronic angle closure or high pressures, I'm not sure. That is something that I have observed. If Minu can add something to that, I will be, you can add something. Regarding the diamond configuration, I think this is one point that all of you have to see. The way she put the hooks. So instead of putting the square hooks and having your main incision separately, have it either just above your main incision. That is one way of doing it. Put the incision and then go under and have another track for the this one, or just like you did, just near the one of the hooks, so that you get a good sub-incisional exposure. And regarding the soft cataract, I think that small trench, making it initially itself is very important. We all make this mistake. I make this mistake even now. Few trenches, it doesn't work, you get irritated. You make it a bowl and then do visco expression. Even hydrodissection you can do. It need not always be visco expression. If it's a thin bowl, you can hydrodissect, one pole prolapses out and you can take it out. But the softer the cataract, the smaller the trench. Don't trench sideways. Have a very narrow trench, and most of the time you will be able to handle it well. Recently I had a very soft cataract. It went into a bowl, just couldn't crack. I tried hand rotor section, it wouldn't come out. The rhexis was slightly on the smaller side. The posterior plate surprisingly was a bit thick, but the anterior one I ate, nothing happened. And then I drenched the central portion and suddenly there was a clear area. So I thought, oh God, no, the PC I have ruptured. Then I sort of panicked and went to the periphery, held with the Sinski hook, lifted it up and aspirated. And I found that where I had put the Sinski hook, I had made a PC puncture. Not in the central area where I thought I had made. So I think this bowel is a very, very tricky situation so you can prevent it much before that, while. So thank you for the time. Binu, you want to make a comment on that? Can you give a mic to Binu, please? Yeah.
95% that I quoted is from a study. It's not my
I'm just saying my experience.
Yeah, obviously. So this study was from Japan and a well-designed one. So I think we need to be more.
Very. Yeah. You have to expect zonal dialysis anytime. But then there are certain conditions where you can.
It's not dialysis.
And weakness. You can anticipate.
Can I have a comment?
Yeah.
I think this zonular weakness is always there. It's comparative, there is a 360-degree pull. So when you try to do the exercise, the counter force is not there, you tend to get a wrinkle. Basically shows zonus are weak, not excessive. So it can happen to any patient, old age, all that.
RP, I have clearly noted that over time they lose zonules, and there are areas where you don't have zonules at all, and there is regression and you have sparse zonules. That is why it becomes globular and chamber shallows, and there is movement, and the folds indicate that the pull by the zonules is not enough. So the zonules are not enough, and that is why you get folds. Without zonal weakness, you don't get folds.
And just like pseudo-exfoliation, RP also, I have quite a few patients who come 5 years, 10 years later with an entire bag, complex, IOL dislocating.
And the fimose also more. And this the second question was about the central, the lifting up the central thing. Only point is that that's a great idea to lift up and eat off the central part, but then make sure you don't occlude. If we occlude the tip with that and you suddenly eat it off, and the next thing you have is PCP. So have the tip partially free and use little bit of energy and don't go high on vacuum. And if you leave a bowl, sometimes if you forget that the central nucleus is not there and think that it is an SICS and you are trying to prolapse, it may prolapse. Forget that the central nucleus is not there, it has not gone.
If you
think that it is there.
Periphery is thick enough.
Periphery is thick enough. Otherwise, with a little bit of hydrodization here and there, it keeps coming in. But the central bowel happening is quite common.
Sandhya, final comments. 2 o'clock.
Another thing is when there are generalized zonal weakness, another option is you can place a 3-piece lens in the sulcus and do an optic capture, so that this haptics will give some haptics will be secured in the sulcus and you can place the optic in the plexus. So that is another option. And for the PD students, if there is severe subluxation, like when the lens is moving, when you have started doing the rhexis, what you can do is you can just do a can opener and then you can do an SICS, which will be much safer for the beginners. You don't have to do all the gymnastics of putting hooks, rings and CTRs and all. So you see that the lens is moving when you start your rhexis. You can just can opener is much more is like it won't give further extension of dialysis and is more safe. So if you're a beginner.
I think as Sony said, the customization is the most apt goal for any kind of ego. So when you see a patient, cataract nucleus, it will automatically